Thank you, Doug. I think I'm all right. Everybody can see my screen. I'm doing okay here?
Yes, we do.
Perfect. Thank you very much. And thank you very much for the invitation to present in this beautiful meeting. I would have preferred actually to travel to Miami, looking at your nice background, Cesar. These days in Germany, it's still pretty cold. Spring doesn't want to start. This year, we will have snow on Monday. So I'm also looking back at the times when we were together in the beautiful island of Martinique. You were all already referring to that meeting, or meetings, I should say. And I'm going to come back to that in my presentation in a minute. My task is to share with you some of the drawbacks and some of the highlights when it comes to radioactive iodine imaging. These are my disclosures, and I'm cooperating with several companies, but also work for patient support groups, at least 3, 1 national and 2 international. This is just an excerpt from a paper that has recently been published, thanks to Dr. Gurlak, in the Thyroid journal. And this is basically our work from the last Martinique meeting when we were preparing talks and presentations before the pandemic hit us. And it's dealing with Theragnostics, and it's also dealing with the group of the intermediate risk patients, and we all agreed that, especially in this group, you should not consider iodine scanning mandatory or not necessary. So everything is within the gray zone. And in the absence of consistent and defined reporting systems, we should use the best we can offer at this stage, and these are semi-quantitative systems. I'm also coming back to the term of Theragnostics. It's a buzzword these days, and it derives from ancient Greek. And as you know, it consists of the therapoin, meaning treatment, and gnostic for knowledge. This is why some people would argue there needs to be a G in between. And this is why I'm partly referring to Theragnostics and Diagnostics. So you will see that in my talk. What do we mean by this modern concept? It's personalized medicine. We should employ the right diagnostic test to an individual patient to optimize therapy using the right dosage, and it should be as targeted as possible. And it's closely related to diagnosis and, of course, to prognosis, and what I like best, it's an interdisciplinary approach. So we want to tailor our therapy based on different parameters, and that includes, of course, pharmacogenetics, proteomics, biomarker profiling, and last but not least, functional imaging. Nuclear medicine is quite easy. It's a very simple example for how Theranostic can be applied, and some people would call it radiotheranostics. A few years ago, we stated in an editorial for the European Journal of Nuclear Medicine that's nothing new. It came back with neuroendocrine tumors and also with prostate cancer treatments and diagnostics, but it has been there for quite a long time, as Cesar already showed us. So again, referring to our recent paper, we should select the appropriate, the optimal therapeutic interventions based on data derived from genomic alterations and also functional expressions. So it has the potential really to create individual treatments, not only based on cytology, we're going to hear about that in the second part of the symposium, but also based on molecular imaging. And As always, the Australians are a step ahead. They have this very positive connotation of Theragnostics, and I like the image very much. This is how they deal with thyroid, hyperfunctional thyroid nodules and also thyroid cancer. So, as I already said, personalized medicine is what we're aiming for, and you all know that 95% will be differentiated thyroid cancer, mainly focused on papillary thyroid cancer, and they have a usually excellent prognosis, and mainly the management of radioiodine refractory tumors. We just heard about that, is still remains challenged. This is the target structure that allows the sodium iodide to get in, and it's the NIS, of course. We heard about that already. And we also should keep in mind rule number 3, that usually, not always, but usually poorly differentiated cells will have less NIS capacity and a higher glucose transporter capacity. And they're both key components for a theranostic approach in DTC. I was also asked to give you a little bit of insight of the radioisotopes that have been used and probably will be used in the future. We're mainly focusing on IDA 1, 2, 3 for pre-operative and also post-operative diagnosis. In some institutions, imaging will be done using IDA 1 to 4 as a PET component, also for dosimetry. IDA 1 to 5 has also been used in the laboratories, and we already heard about iodine 131 being the working horse still these days. In Germany and in Europe, we also use a lot of technetium. It's easily available, and we use it for diagnostics of hot nodules, also pre-therapeutic and post-therapeutic, when you can see that after therapy, a hot nodule turned to a cold nodule. In the Theragnostic concept, I always tell my colleagues, it's quite simple. We use iodine as the Trojan horse, already established some time ago, and this is our Trojan horse these days, a simple capsule or a simple shot. My team members tried muffins once, but it didn't work. Probably one of the drawbacks or pitfalls Doug was referring to. So when should we do radioactive iodine imaging? Before first iodine 131 therapy. After therapy, we heard about that. The time span matters, 3 to 10 days, probably twice in this time period. And also, I learned from Doug van Nostrand that even post-therapeutic scanning, so after adjuvant therapy, makes sense to establish a new baseline. And I think this is a very elegant concept, and we do that on a regular basis. And in some cases, you also need to restage the patient when TG is coming back and TG is increasing. So in this case, it's always nice to look at the baseline scan. So there are 2 general strategies adopted in the post-surgery setting. It's pre-RAI treatment imaging and post-RAI treatment imaging. This is one of the main controversies these days, if we need a pre-treatment imaging, and if this really impacts on the dosage for adjuvant treatment or ablation. Funny enough, I gave a presentation a few years ago, and nothing much has changed since my presentation at the ITC, the International Thyroid Conference, because regarding a diagnostic whole body scan after surgery and radioactive iodine treatment, most of the citations are quite old. So the colleagues from the ATA would call it a strong recommendation, a moderate quality evidence. But all these papers are dating from the early 2000s, usually before the advent of SPECT CT. So I would call it a very weak evidence to really exclude post-interventional scanning. So what are we depending on? Cesar introduced the term actionable information. I like that one very much. But depending on the biological attitude of a tumor, I already told you about the isotopes. The imaging technique is very important. And of course, the amount of radioactive iodine you will administer. And overall, iodine 131 is not the optimal tool for scanning. Also because we use quite low activities to avoid stunning. And sometimes it's underestimated that it might be quite complicated to really tell the difference between metastasis in the neck, nodal metastasis in the neck, and remnants. So again, detection is based on biological factors, on genomic associations, and of course, those genomic associations impacting on the iodine metabolism. Let me stay with this cartoon, this graph for a minute, because this is my favorite slide, and it goes back to my friend Herbert Henscheid. And it shows you that besides biology, physics is what really matters when it comes to nuclear medicine. And I know that some of the endocrinologists will be scared by this, but still I try to take you through this. It took me some time to understand. Basically, it's not only biology, it's also physics. And we're talking about the limit of detection. And this is dependent on the image acquisition time, how long will you scan the patient, and it's dependent on the administered activity. And you can see there's a wide range you can use, like 10 megabecs or 7,000 megabecs. And you can see the limit of detection on the scale here. And it really makes a difference what you're looking for. And you also have to correct for the depth of the tissue. So it makes a difference, and we're not talking about the camera, we're not talking about the equipment here. So following up on what Dr. Nostrand already told you, it's not a black and white thing if we call a tumor positive or negative. Many influencing factors, and you can, if you have less radioactive iodine, of course, your limit of detection will be much lower than after post-therapeutic scan. So this is just an example. If you go for a 5-minute acquisition after 75, or you use a longer acquisition time of approximately 20 minutes and a higher activity. And it's much higher after therapeutic administration, and I already alluded to the camera efficiency. So everything is changing these days, but there is some underlying concepts on physics. When it comes to image interpretation, this is of course another hurdle we have to take, and it's sometimes really challenging, and it influences the accurate staging of the neck. So we use SPECT-CT and in some cases PET-CT to have the morphology, the underlying morphology, which is much nicer than planar scanning as we did in the old days. And these are all potential sources of uptake, like inflammation, other tumors, breast and breast milk. All these things can be falsely positive on a radioiodine scan. It's not that rare we see images like this. This is a patient presentation, the TG, post-operative TG, I should say, of 42 under TSH stimulation. And this is after therapy. We used 370 megabecs for post-interventional scan. TG went down to 1.5. And we were asking ourselves, and I might as well ask you, if I was in Miami, I would, you could raise your hands. What would you do in this case? Would you give another therapy, external beam? Probably not. Surgery again, and just wait. So we waited another half a year, and without any intervention, TG went down to below detection limit, and the scan was basically negative, or almost negative. So nothing else to do than to wait in these patients. And this shows you the following scans. So we're getting much better. We use planar X-ray. Now we're up to PET MRI, and in some cases it showed to be superior even to PET CT, especially in the neck. Funny enough, so far we don't have a well-established and validated tool to really quantify responsive therapy in thyroid cancer. It was applied, of course, when we used TKIs. With the advent of TKIs, there needed to be some scoring system, and of course, RECIST was one of them. So between institutions, it's still hard to compare scans and to really define the success of radioactive iodine, or to call a patient RAIs or assisted. I'm not going to dig much deeper here, but again, referring to the paper by Dr. Gulak, nicely summarizing the potential tools and diagnostic scanning modalities we are using and their pros and cons. So after RECIST, some years ago, PERSIST was also established, a quantification system for PET scanning, and I'm going to talk about PET scanning for a few minutes now. This is the old days when we did radioiodine scanning. It was at the beginning of my career, we still had one such a scanner, very sensitive tool, also very loud in the background. And now we're all working with SPECT CT, and it really adds to the picture. It's much easier to establish the nodal status. We have more precise anatomical localization of lesions, and it clarifies a lot of undetermined findings. Here's an example. This is again the star phenomenon, and you can see that there is a remnant here, and you have lymph nodes all over the place, and you can also do slices here, and the surgeon went back in and she found 33 tumor positive lymph nodes. I'm not going to talk a lot about radioiodine refractory because you just heard about that. I like the cartoon of Dr. Cabanillas in the Lancet. Sometimes patients will respond in some of the lesions and others will not respond. So why don't you give it a try and also monitor the patient with the FDG. As Doug already alluded to, there are only degrees of likelihood, and I wanted to repeat that, although I know he was talking about this topic. And not all scans are created equal. That's also a phrase I loved when he was presenting on the island of Martinique, so I included that in my presentations, and here we go again. And of course, there are other options than only the radioiodine administrations. You could also go for surgery, radiation, radiofrequency ablation, cryotherapy, or embolization. There are multiple tools, and in these challenging patients, progressive patients, you need the whole spectrum of available modalities. Some of the confounding factors that were also mentioned by Doug already. What are the metrics for successful response, the duration of response? What about the amount of radioiodine you have been using? Can you give even more? And what's the risk to benefit ratio? So which PETs to get? It's not always straightforward that you see a positive uptake on the iodine PET CT. Using iodine 124, which would be negative on the FDG, and vice versa, the lung lesion having a high glucose uptake and negative radioiodine uptake in fully differentiated thyroid cancer. But we can use FDG in many cases. In initial staging, if you have a high-risk patient, restaging in case of rising TG, probably not only in the case of negative radioiodine, and also for response evaluation in TKI therapy. This is another example of showing the complementary value, negative iodine 131, positive glucose scan. And this nicely illustrates they can find very small lesions here in the bones in an advanced thyroid cancer case. And it's not that simple that all the iodine positive will be FDG negative, but there is a gray zone and an overlap, and some patients will have both types of uptake, FDG and radioiodine, even within the same lesion. Another example here, FDG positive and only one lesion showing radioiodine uptake, probably not the ideal candidate for the conservative radioiodine approach. And this may be due to resistant clones showing up after several courses of radioiodine. It's perfect for the imaging after TKI treatment. We do that on a regular basis once we start treating patients with lenvatinib, sorafenib, or what have you. And it's also the perfect tool, the iodine 124 PET CT, if you need to assess redifferentiation. And you can also do lesion dissymmetry. I'm going to come back to that in my presentation tomorrow. So the current ATA guidelines look for a more liberal use of PET scanning, and I showed you some of the examples. Finally, there are some options for the future as an outlook. Probably Dr. Gulak will operate, probably already does, with the help of this new technology. It's a handheld imaging probe, and you can do SPECT CT on the operating table. I don't have any personal experience in that, but I think it looks quite promising to me. And then you can even do fusion with the ultrasound images you documented prior to the intervention. So let me summarize. Risk stratification is still the most important part in treatment planning. Funny enough, so far we don't have a uniform classification system, and we need that. Probably the Martini group is going to work on that. Components of a response assessment system should also include functional imaging, as I showed you. We need to really redefine the role of diagnostic RAI imaging. Probably the new baseline is what needs to be considered. And as you know, molecular markers play an increasing role in the management. So far, there is no gold standard imaging technique. A tailor-made approach is the best we can do at these days. And we have a growing number of new PET tracers, and I'm looking forward to that to better characterize the tumors. And this is a beautiful image of our marketplace. And with that, thank you for your attention.